So what we want to show is the mass itself without showing the patient. So there you can see it, all right? So we've sedated the patient with ketamine and with Ativan, so there's no way that she's going to know what we're talking about. And we're not going to show her face. But this is common among MHCU patients, all right? Willful non-passage of urine. There is a technical term for it. I'd love if somebody could check it up. And there are a few documented cases of it where people will actually do this, you know? All right, so basically what I'm going to do is show you guys how we're going to aspirate anything via ultrasound. All right, so I've got my needle, all right, nice large bore needle with the syringe. All right, now you can point it at the screen. All right, so what we've got over there is we've got Dr. Masilela, who's holding the probe in place for me. All right, just so that we can see the skin and try and get it nice and close on the skin. So you can see we're right there, and there's all this fluid that's sitting inside. All right. So I'm just moving a little bit off the midline because I just want to keep it in the middle. There we go. All right. I'm just going to clean a little bit. That's about it. Just concentrate. Sorry. So what we're going to do now is we're going to actually watch for the needle. All right. So she's under anesthetic, so not to worry. She might react a bit, but not too much. So what you'll see there towards the middle of the screen is you'll actually see a movement. All right. And that movement is actually my needle. The needle itself can't be seen on ultrasound, but you can see where your needle is based on that bouncing movement. All right. And then we pass in, and there we get a whole, now you can show the urine down here. All right. So you've got a whole bunch of urine. So don't think everybody who presents to you and talks normally is a perfectly normal patient. She's got some underlying MHCU problem. She will now go to Euro, because they need to figure out what if there was a physical blockage that was causing this. But more than anything, she also needs a psychologist, and she needs somebody to have a look at her to decide why she retained her urine for that long. Okay, so odd case, interesting case, one of those cases you read about in the journals once in a while. So we're going to drain out the urine. So all that we've done, we haven't gone against the wishes and put in a catheter because she point blank refused. What we did first was we took a consent for an intra-abdominal aspiration, which is exactly what this is. So that means we've covered ourselves medico-legally as well. We've got an IV line running down to a bucket at the bottom, which is something that you can do as well if you don't have a suprapubic catheter and a patient who's also got urinary retention. So that's just a trick you can use, and after that we'll just secure it, and that's that. Okay, thanks.